Episode 19 of the BloodStream Podcast, as well as episode 18, 17, 16, 15, 14, 13, 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1 are brought to you exclusively by Shire. And for that, we say, thank you, Shire.
So I threw this bowl one time.
Through this bowl?
Yeah.
Like ceramic style?
Yeah, on the wheel.
Okay.
And then I glazed it, and it came out of the kiln like right when I was leaving. So it was like still pretty warm. And I walked home, and it was in the winter. And I got home, and I placed the bowl on my table, and I hear ping, ping. And like for weeks, it just made noise. Because like
You had a haunted bowl.
I did. But like, how cool is that? And then I looked it up, and it like that happens sometimes.
Weird.
Yeah.
All right.
So I had a piece that sang.
Wow. All right.
And it was a really beautiful piece too.
We've recorded that for forever now.
It was recording.
Hello, and welcome to the BloodStream Podcast, episode 19, December 18th, 2017. I'm Patrick James Lynch.
And I'm Natalie Lynch.
On this episode, Hemlibra is FDA approved, and the first non-factor replacement therapy to treat people with hemophilia A and inhibitors is now on the market. We'll discuss that, along with the other major product development takeaways from the American Society of Hematology's annual meeting held earlier this month during our comment segment. Natalie will present a story on how new HIV guidelines are revolutionizing patients' lives in her Like segment, and community member Angel Parrett shares her story of living with Factor 1 deficiency, a rare factor deficiency, in today's Share segment. Plus, I sit down with NHF CEO Val Bias to review some of the major community highlights from 2017 and to look ahead at what's to come in 2018. All that and more coming up on this episode. Welcome to BloodStream. We're here, Natalie. End of the year, December episode.
I know. Wow.
Yeah.
I mean, I'm not sad to see 2017 go,
No,
to be
it's
honest.
time. It's about time.
New year, new beginnings.
Yeah, at least hope.
Let's all get fresh.
Sure. We can all use a reset button, I think. I think this year has done everything it can do to us. So we were actually just recently in a pretty unique situation. Actually, we were supposed to be recording this in that unique situation, but unfortunately my GI tract didn't agree with that decision.
Yeah, we were in India.
We were in India.
And our intention was to record this from India, but
basically just so we could say we're recording this from India. Like,
yeah.
That was kind of the only real...
I mean, we literally could have done it today and lied, but we're honest.
Oh, we didn't
here.
even think about that. We should have thought about that. That was an option. Nobody needs to know we're in Brooklyn. Who cares? Silly Brooklyn. But yeah, we were there with the WFH. As regular listeners know, Believe Limited does a lot of work with the World Federation of Hemophilia's humanitarian aid programs. So this year we were with them in Indonesia, Armenia, and then most recently India to do different content capture around how their expanded program, the availability of more donated product, has enabled, bottom line, better quality of life and care for people with hemophilia. So in India, we were specifically looking at non-emergency surgeries and corrective surgeries that were enabled by increased factor product. And for the first time, Natalie was able to come on one of these trips and see kind of what that work is all about and get to experience a little bit of India and some community there. You got to bond with some community members in some pretty intimate ways, too.
Yeah, I mean, it was really cool to... I mean, I always love meeting partners of people with hemophilia because it is a special role, and we're a part of the community, but also, like, it was interesting. I was... the woman I met and who welcomed me into her home, her very humble and lovely home,
Mm-hmm.
it was just like, oh, sometimes I'm feeling, sorry for myself when I feel like you have a bleed, and not sorry for myself, but like as a wife, just feeling like emotional when you're hurting.
Mm-hmm.
And like, we have all the comforts in the world here
Right.
in the United States. And to think like,
They don't have running water or electricity.
yeah, and like you've got like other worries, and your husband like just got his leg amputated.
Right.
So like it was really eye-opening to me, and to be able to connect with her as a woman to woman, as a sister to a sister, and as a wife of a bleeder. Like
Yeah.
it was really special.
It was cool to observe that too, and to see those connections. And I think it was cool for her and for the other people that you were there engaging with, because you are a community member, and when I'm there as community member and patient, I'm working, right? So I'm doing the things I got to do. You're there in a capacity that allows you to have, longer conversations, kind of chat on the sidelines with people, and
Play
that's really
with
valuable.
children.
Play with children.
And that's like my best job.
Yeah. So yeah, it was really cool. We had a good time, and I'm really proud of the work we did. We got a lot of content for this short film. We have like 20 interviews, and I don't know how many hundreds of hours of footage all together for something that is going to just be a several minute long
Always
video.
trying to make your job harder.
Yeah, so that'll be next week, going through transcripts and trying to figure this out. But I would recommend check out treatmentforall.org. You'll see the most recent video that we did, which is on identification in Indonesia. That was from earlier this year, a few months ago. If you haven't seen it, check that out. And then this new video should be up there probably sometime in February. But of course, we'll make that announcement here. So that's pretty cool. And then this morning, I got a neat email. Actually, in a couple hours here, I'm going to be going on the BBC's Outside Source radio show to talk about, guess what? Hemophilia. That's my topic. And gene therapy and the promise of gene therapy. There's been a lot of articles, and we're going to talk about this more in a little bit, about some of the data presented during the American Society of Hematology's annual meeting, ASH, this year. And one particular set of data that was presented on gene therapy was quite exciting. So there's been a lot of hubbub about that. So I woke up to an email this morning from London saying, they found me online, found me on Twitter, and asked if I'd be willing to come on the show. So in a couple hours, we're going to stop recording this, so I can do that real quick before we finish it up. I don't know if there's going to be a link or anything I can share. It's a live show. Not really sure. If there is, it'll be in the program notes. So you can check those out. If not, then, just assume I said something really smart. A couple other pieces of business, right? That seems like a decent little compromise. A couple other pieces of business. We got a new episode of the Ask the Expert podcast. This latest episode features Pat Torrey, the CEO and founder of Gut Monkey, also known as Big Dog. And he comes on to talk about outdoor experiential education, and really not so much the X's and O's of it, but really more the philosophy and mindset of why outdoor experiences and outdoor education matter. And particularly for people with chronic disorders and bleeding disorders. So I recommend checking out that episode. It's great to hear from Pat. If you've never heard Pat speak and talk about the outdoors and his beliefs in it, he's an inspiring speaker. So I highly recommend that episode. And we got a new episode of the Powering Through podcast, which features our Powering Through held earlier this year at the Hemophilia of Iowa's meeting with community members Brody Nolte, Carrie Atkinson, and Chris Bombardier. So you can check both of those out if you go to BloodStreamMedia.com. Click the links for the respective podcasts where you can stream, subscribe, or download. Stream, subscribe, download. Yeah, one of those.
Whatever you want
to
do.
The episode of your choosing. And don't forget, you can keep up with us on social media, facebook.com/BloodStreamMedia, at BloodStreamInfo on Twitter. And if you haven't already, please make sure to subscribe to us on iTunes or on your phone's podcast app, or wherever it is that you listen to podcasts. Subscribing is a way to make sure that you get the most recent episode delivered directly to you. And as always, you can send us your feedback, ideas, or submit your short essay for consideration as a future share segment by emailing mailbag@bloodstreammedia.com. Kicking off the like, share, comment segments for this month. Our like story brought to us by Natalie. I don't feel like a threat anymore. New HIV guidelines are changing lives. Natalie, what is that all about?
Well, it was an article written in the Washington Post on November 24th, and it basically talks about the big news that came out, the undetectable equals untransmittable, or U equals U.
U equals U? Oh, yeah, undetectable.
Wow.
I was like, why U's? It's undetectable and untransmittable.
Yeah.
Where'd the U's come from?
All right, do the math.
Yeah, sorry. It's early in my brain still. I'm still on India time. Still recovering from my my bout of illness to finish that trip. But sorry, go ahead.
So who does this affect? The 1.2 million Americans living with HIV. And what was interesting reading the article is this isn't a new concept.
Well, can you dig in a little more? Like, what does this concept mean? What does that actually mean?
So it means that if there's an undetectable viral load, that you cannot transmit the disease to your partner sexually. And how do you have an undetectable load? Well, you're taking your medication regularly. Once considered a death threat, now it's a manageable chronic disease, HIV,
and one that isn't necessarily transferable.
No, so an undetectable viral load is when you have less than 200 copies of the virus in 1 milliliter of blood. So
Okay.
if you have less than 200 copies for 6 months, you're considered no longer capable of transmitting the disease. So patients and doctors have known this for years.
So why is it coming out now?
I mean, but it was like sort of like a quietly understood. Like in doctor's office, like they would talk with their patients about it, but it just wasn't widely accepted. And in July, Anthony Fauci, I hope I'm pronouncing that correctly,
Sorry,
the head
if
of
not, Anthony.
the National Institute of Allergy and Infectious Diseases, publicly agreed at an international conference that people with an undetectable viral load in their blood cannot transmit the virus. Then in September, the CDC basically came out and like agreed with that. And now there are more than 500 organizations in 67 countries saying like agreeing with this. And Bruce Richmond is leading the Undetectable Equals Untransmittable campaign.
And what does that campaign entail, or what is it all about?
It's changing public perception, which I thought was interesting too, because I really, and I'm someone who reads up on health and who knows stuff. I'd like to think.
Yeah, you know stuff.
I know stuff. Definitely before reading this and before it came out this fall and all these organizations stood behind it, really would have assumed that, like, had someone declared their status to me, I would not have been comfortable of having unprotected sexual encounter with them.
Sure.
So, like, it's important to change the perception. And then there are social impacts of this, of, people now maybe using condoms less and passing on other
right.
STIs.
Right.
So
I wonder in a way if that was part of the hesitance over the last number of years to kind of push this into the public discourse, if part of the hesitation was around, what kind of behaviors might this influence, what might this affect, and do we want that? You know what I mean? Like,
right.
Because it's not, on one hand, like, that's fantastic, but on the other hand, you don't want it to now become a reason that people do start having unprotected sex and taking riskier behaviors because they believe themselves to be, enable, and they might not be able to transfer HIV, but like you said, there may be other things going on that now they're exposing themselves and partners.
And their partners too. I mean, the rate of new infections from 2010 to 2014 dropped 10%.
In the U.S.?
Yes, in the U.S. So we're getting, there is a big change in this community. And it's nice to see those numbers going down.
Yeah, although there are pockets where it is still going up in the U.S. as well. So like nationally that figure is true. But I know from talking with Jeannie about this stuff, Jeannie White, major HIV/AIDS activist advocate, there are still pockets in this country where the numbers are on the rise. So also good for us to just keep that in mind too.
Yeah. So, so it's not a new idea. And in 2008, the article states that the Swiss came out saying this, but like the world just wasn't ready for it yet.
Poor Switzerland's like, hey guys, we got something to say. And we're like, nah, let's go back over being neutral somewhere.
Yeah, so doctors, patients, Switzerland have been saying this for a while.
Yeah.
But now it's, and now like that the CDC and...
Right. Now, with the CDC making a statement, I mean, that's I guess, what kind of triggered this to be a WAPO story now, is that the CDC has now
and over 500
this.
Organizations in 67 countries are saying, like, if you have an undetectable viral load, less than 200 copies, that, and like, how great is that for, like, couples who've been married and one of them has had HIV for 30 plus years?
Yeah.
To now know, like, okay, if I'm on my regimen and like, I won't give this to my partner.
Yeah. Or couples who are, still of birthing age, who can now like have a child through, natural process without needing any kind of intervention.
Yeah. So it's just, it's exciting news. And I think for the community who's affected by HIV, our community members, like, it's a great, it affects the self-identity and
big time.
Just it's a positive.
Cool.
So.
Well, that's very cool. So we'll have a link to that story in the program notes if you want to read up on it and do any additional reading. Thanks for presenting that.
My pleasure.
And now in today's Share segment, Angel Parrett shares her experience of living with what we call a rare factor deficiency, Factor 1 deficiency.
What is Factor 1 deficiency?
So the NHF describes it as a collective term for actually 3 rare inherited fibrinogen deficiencies. So to actually go over to Angel's description for a moment, because I asked her the same thing, can you describe in your words what Factor 1 deficiency is? The simplest explanation for what Factor 1 describes is fibrinogen is the protein that seals the clot. So after Factor 8 and 9 and the rest have done their job, without fibrinogen, there is no way to seal the fibrin glue. The challenge in treating this has been that it occurs so rarely, approximately 1 in 1 to 2 million people. And up until 2009, there did not appear to be a market for improved research leading to better treatment. Again, this is Angel's take. So that's why she went so long without Factor, as she states. And from what you can see now, things have changed a little bit. So hopping back over to NHF, there are these 3 different conditions with very long, challenging names that I won't try to say because I'll butcher them, but essentially it's any one of these 3 that influence that part of the clotting cascade, the fibrogen actually kind of like sealing the deal at the end of the kind of treatment flow. And it occurs equally in men and women, but only 1 in 1 to 2 million people. So it is extraordinarily rare. And as she references, up until recently, there hasn't been a whole lot of advanced research on this for better treatment. So that's what it is in a nutshell.
It's so interesting. Before I knew you and before I knew bleeding disorders, but if you just think of like blood clotting, all the little elements that have to come together for this to happen. Yeah. You think of like all the body's processes.
And then all the ways it can go wrong.
Yeah. But that like, even with you, at least for me, I think like, oh, my blood clotting, it's just like maybe a couple things come together and do it, but it's like really complicated.
It's really complicated, yeah. So I hope that description gives people at least a layman's understanding of Factor 1. And let's move into Angel's story.
1 in a million. Factor 1 deficiency. As someone with Factor 1 deficiency, my journey to fit into the bleeder community has been long and full of many twists and turns. Growing up around Cincinnati in the 1980s, I had access to excellent care, but up until just a few years ago, Factor 1 had no concentrate to treat with. My only product was cryoprecipitate, which necessitated visits to the ER and/or HTC for every bleed. So unlike many of my peers within the community who are enjoying the benefits of home care, I could only wish that day would come. In spite of this, my quality of life was relatively high. I had fairly normal school attendance. Most bleeds were minor and treated on demand, and I was allowed to do almost anything I wanted, within reason. But at the age of 18, I was hit with a curveball that proved to be more difficult than even the most complicated bleeds. Like many of my generation, I was faced with the diagnosis of a deadly virus from contaminated blood product. While preparing to go to college, I was told that at some point my cryo treatments had given me hepatitis C. Neither my family nor I had any idea what to do. The moment was life-altering. We were offered what treatment there was for hepatitis C, but the side effects are brutal. Most significantly, I experienced extreme fatigue, which interfered with my ability to successfully transition to college life. So I abandoned treatment after maybe a month. Like with my limited treatment options, all I could do was go on with life, trust God, and pray for a cure. But I didn't let my Hep C diagnosis slow me down. I got 2 college degrees and started a career I love, all with very few bleeding issues. And at the age of 35, the things on my wish list started to come true. On November 13th, 2014, I received my first ever infusion of fibrinogen concentrate. To this day, it has been successful. Access has been a challenge at times, but always worth it. Once I started on Factor, the next item on my wish list was home infusion. This was a long fight that took a lot of research, but Independence Day came on September 21st, 2016, thanks to our great team of pharmacy staff and home nurses. But unfortunately, after 9 months of home care, my stubborn veins decided they weren't having it. The head of my HTC refused to allow ports for anyone for any reason, but I wasn't giving up my independence without a fight. Earlier that year, a younger MD had started in Cincinnati, and I wanted to see what he had to say before giving up. He heard my story, did some research, and didn't hesitate to order a port. On September 6, 2017, my port was installed. Finally, independence had come full circle. In the middle of all these advances, my hematologist gave me the chance to treat and very potentially cure my hepatitis C. By the grace of God, it hadn't been causing me any problems, but of course I was still eager to get rid of it. Treatment began on May 5th, 2016, and after 12 weeks of dosing and 6 months of follow-ups, I was declared cured on January 24th, 2017. I made it through these challenges because I was able to reconnect with my wonderful blood brothers and sisters. My family and I had been involved with the community when I was young, but I took a step away in my 20s because I didn't always feel like I belonged. But thanks to social media and several well-timed meetings, I got the encouragement to keep fighting for the solutions that are becoming available. Nothing about these past few years would have happened without God and my hemo family. From hearing stories of surviving challenges much worse than mine, to being cheered on by many walking the same path, I am proud to be part of such a resilient community. I'm still learning and growing daily, and I hope to attend HFA's symposium in 2018. It would be my first national event. We are all in this together, and I hope to meet more of you along the way.
Thank you, Angel, for contributing that piece on life with Factor 1. And, as she mentions right at the top there, you can definitely hear the similarities in her journey to other journeys we've heard of people with hemophilia, with von Willebrand disease. Some of these stories, they do take a similar shape, even if the diagnoses and the locations and the people are all different.
Yeah, what strikes me is the connection to dates and the connection of these really life-altering moments that happened because she was able to infuse at home and, the day she got her port and, that life changed from that moment on.
Yeah.
It was the before and after.
Yeah.
But that's similar in a lot of stories too. The day I tolerized that, that there are these moments that it was pretty unbearable in some regards to have this before, and then now life feels better.
Yeah, for sure. It's in a couple minutes here we're gonna have the interview with Val. The same day we recorded that, we did a different interview with him for Bombardier Blood, the documentary about Chris Bombardier's summit of Mount Everest and global hemophilia. And in that, my questions to Val were much more specific to him and his life with hemophilia and HIV. And he too, I think I cited specifically at one moment, he had a bunch of dates that stick out in his mind. And you're right, those dates do kind of just stay with you because they're life-changing events for people. I want to mention, I did follow up with Angel to ask about the hematologist who did not allow for ports for any of his patients, just to ask her, what was that about? Because I hadn't heard that before. And he doesn't, because he's just had too many complications with ports with his patients. So it's in his, purview, that's just not something that he's comfortable with, which is fair. I mean, if you are not comfortable because you've seen too many complications as a physician, I suppose it's within your right to
make a choice.
Yeah, and to stick by that. But to Angel's credit, she sought out another medical doctor, found a younger medical doctor who did some research, came to understand what was going on with her, and was, comfortable with the port. So that is just a good reminder that you have to advocate for yourself, and you're not always going to get the answer you want right away.
But it's available. It's finding the right care team for you and your desired outcomes.
Right.
And it's in the birthing world the same thing. So
yeah.
It's no matter what's going on, you need to find, if you're hitting a lot of resistance, you need to find
Just keep going.
someone who supports your vision,
Yeah.
your medical vision.
Supports your medical vision. Well said. All right. Thanks again, Angel. Now for the episode's comment segment, Hemlibra and other stuff. That's the official title of it. Hemlibra and other stuff. So, as we mentioned in the cold open to the previous episode, just before we had gone live with that episode, there was the announcement well ahead of the fiducia date in February that Roche Genentech's ACE910 turned emicizumab was now FDA approved for people with severe hemophilia A and inhibitors under the name Hemlibra. So Hemlibra is now on the market, the first non-factor replacement therapy indicated for patients, both adult and pediatric, with severe hemophilia A and inhibitors. So that's super exciting. There was some speculation that it might be approved just for adult patients because there were some adverse events in the clinical trials, and the FDA can be a bit conservative at times with indications of new products. But, additional data does state that 95% of children who received Hemlibra in the clinical trials experienced 0 treated bleeds. So very, very, very good data to support why both adult and pediatric patients now have this available to them. Also worth mentioning that there is a price attached to Hemlibra at $482,000 for year 1 and $448,000 for the years thereafter. The article that I am pulling this information from also states that is about half the cost of what it is to prophylactically treat with FIBA, one of the 2 bypassing agents for people with inhibitors. So really exciting news, a paradigm shift in treatment. The first non-factor replacement therapy is available and on the market. So for those out there with inhibitors or family members that have inhibitors, this is the time to talk to your HTC and talk to your physician about, is Hemlibra the right decision for you, particularly those for troublesome inhibitors. But as things go, it's almost like this is already old news because this came out a few weeks ago, and just last week at the American Society of Hematology, or ASH's annual meeting, there was some really striking data presented on gene therapy, which kind of stole some of the headlines from ASH, or made headlines, or were the headlines, or I don't know, choose your whatever. But BioMarin's product in particular, that was used in 9 adult men, 1 injection, and those men were followed for 1 year. Very, very, very good data. 3 different cohorts. It was a phase 1/2 dose escalation trial, so trying to assess, the dosing of this product, of this gene therapy product. There was a low dose, intermediate dose, and high dose cohort, and the data was very strong. Likewise, Spark also presented their gene therapy data for SPK8001, their hemophilia A treatment, BioMarin's hemophilia A as well. And Sparks showed 100% reduction in annualized bleed rate, 98% reduction in annualized infusion rate. However, in some independent analysis between Spark and BioMarin's products, the advantage was given to BioMarin. And for anyone who also pays attention to stock prices of these publicly traded companies, Spark's ticker certainly took a hit with that assessment of BioMarin's being in a stronger position. And as best as I can understand from my reading, it kind of came down to the dosing, and how the dosing with BioMarin's products was a little bit more predictable and understandable than with Spark's. So with Spark, for example, there was one patient who it was in the high dose cohort, and they produced clotting factors as high as 12%, while someone in the low dose cohort produced clotting factors as high as 24%. So perhaps that range just kind of suggests that there's more work needed to better understand how Spark's product specifically works, and therefore BioMarin's is looked at as being a little bit further down the line, even though both are in this phase 1/2 dose escalation phase of study. So just something to keep an eye on. Gene therapy continues to roll right along, just as we're in this paradigm shift with non-factor replacement therapies and Hemlibra. We are also on the precipice of the very next paradigm shift in gene therapy. Worth mentioning, too, that Spark also has a hemophilia B therapy, SPK9001, something that they're developing in partnership with Pfizer. Data presented from that, or actually data announced ahead of ASH, I don't know if it was presented there or not, showed an annualized bleed rate for all 11 participants was reduced by 97%, while annualized infusion rate reduced by 99%. So some pretty good data on the hemophilia B side of things as well. A couple other product announcements that I think are just kind of worth mentioning. We talked earlier this year about fitusiran's trial, the Alnylam RNA interference product. There was a patient death on September 7th that halted their clinical trial. Well, FDA officials at at the FDA, that's where they work, they've agreed on safety measures and a risk mitigation strategy to allow the resumption of clinical trials for fitusiran. So fitusiran is back to its clinical trials. That is also a non-factor replacement therapy, completely different mechanism of action and way of operating than Hemlibra, but it kind of belongs to that similar non-factor replacement therapy class, so to speak. So we'll see how that trial proceeds now that it is back up and running. And then final thing, another interesting headline that I saw, Shire and I don't know if it's Rani or Rani, R-A-N-I, they have partnered on the development of a pill to treat hemophilia A. So this company, Rani Therapeutics, they do have a history in oral therapies. None, as we know, exist currently in hemophilia. There are numerous challenges and considerations, but they do have a legacy of this, and Shire obviously has a long storied history, Baxalta Shire, in hemophilia. So very beginning of that was only announced a couple of days ago, so we'll keep eyes on that as well. And that's about it. I'll just mention too, I was looking on Twitter, and it seemed as though all the hype was around these gene therapy sessions, packed rooms, people spilling out into the hallways, everybody in the global community. Their attention is on how gene therapy is really promising something special for our community. And finally, there were a number of different kind of on-the-fly interviews that different outlets did while at ASH. One of them, Rare Doctor, raredr.com. They did an interview with Dr. Guy Young, pediatric hematologist out of the Children's Hospital of Los Angeles. He was heavily involved in the work done on Hemlibra, and he has a nice 3.5-minute interview that just kind of gives an overview of treatment in hemophilia up until this point where we're at now and where we might be soon with gene therapy. So we'll put a link to the program notes if you want to hear from Dr. Guy Young and his kind of take on the state of the union in hemophilia. You can check that out as well in the program notes. All right, so did you soak everything up from that comment segment, Natalie? There's going to be a quiz. You ready?
I mean, you saw my face. Sometimes you just get a little chatty.
She gets wide-eyed. Chatty, there's a lot of stuff to talk about. I got to cover a whole bunch of different crazy, highly scientific medicine stuff.
Less often, less invasive, and less bleeds. That's what I took away.
That was your Hemlibra takeaway.
Well, yeah, and like the pill and, you know, and gene therapy's exciting.
I think you should do the next comment. Say, less often, there's a pill, gene therapy's exciting. I'm Natalie.
I mean, we could put a poll out to our listeners.
Yeah, do you want to get some information or do you want Natalie to be cute for 45 seconds in the comment segment? Your choice, listeners. Come on.
I mean, I basically summarized it really quickly.
Yeah, okay.
Well, and so I was thinking with gene therapy and with a, quote, cure for hemophilia, how would you feel like if you were cured? How would that affect your identity?
I don't know. I mean, I haven't really spent time thinking about that, to be honest. I mean, I certainly would want to be. Like, it's not as though I'd be like, I got to think about my identity here. You know, like cure me. And then I'll deal with the identity afterwards. I mean, the thing is, like, you know, and actually we have the interview with Val coming up here in just a moment, but I've heard him say this before. When we talk about a cure, what is it we're talking about? Because hemophilia A is different from hemophilia B. Angel shared that piece today on factor 1 deficiency. We've done a lot this year for the von Willebrand disease community, and my big focus from a community standpoint really has become the global community and the fact that 75% of the world, aka most of the world, does not have access to predictable, sustainable care. We see what we saw in India and what we've seen in Indonesia and Armenia and Nepal, etc. So it's not as though there's just going to be a day where everybody's cured and everything's better. You know?
No, but I'm asking you the hard question of you personally. Like Patrick James Lynch, no longer a man with a bleeding disorder.
Yeah, like that doesn't, you know, I'll still be a man with arthritis. I'll still be a man who lost my brother to this thing, and I'll still be a man who is highly involved in whatever what I think are the most pressing needs in the community. So I don't think my identity is going to change too much because I know I have it, obviously, but I don't first and foremost identify as a patient. I identify as an advocate and a content maker who's trying to use content to make a difference. Like that's where my identity is really more wrapped up. And that isn't going, you know, that'll have evolutions, but it won't go away. So I think that would be the harder thing for me, actually. Even if I continued to have hemophilia, but if I stopped doing all of this work just like at the drop of a dime like that, I think that would actually be the harder identity battle than being cured of hemophilia but continuing to do the work.
Interesting.
Yeah. Yeah.
I mean, there are people in the community who essentially are cured, right? Ones who have had liver transplants for Hep C and no longer...
Glenn Pierce, yeah.
So, these people do exist. Someone who used to bleed and doesn't.
It'd be interesting to ask him that. I've never asked him that, if he had any kind of a psychosocial adjustment to what it meant to like not have hemophilia anymore.
Yeah. Maybe I should start interviewing people.
Yeah.
Really getting in there.
Yeah, do the comment segments. You do the interviews. We're going to take this thing to a whole nother level.
Welcome to BloodStream. It's Natalie Lynch and Natalie Lynch.
Okay. Really carving out this fiefdom for yourself.
Anyway.
All right, so with that, we should get into the interview with Val. I do want to mention, he and I talk about emicizumab speculatively. We did this interview a couple weeks ago, so that was before the announcement was made that Hemlibra was now approved. So you're not going to hear us say Hemlibra. It didn't exist at the time of the interview. You're going to hear us talk about emicizumab and forecasting it's potentially coming out, and some other topics that we cover. We go through a lot: insurance, the fight to protect healthcare, the new products that are being developed, VWD, Glanzmann's, and rare factor deficiencies, the use of the word hemophilia versus bleeding disorders, progress with women with bleeding disorders, Spanish speakers in this community, and more. So a lot of stuff to get to in this interview with Val. I hope you enjoy it. All right, so I am here with NHF CEO Val Bias. Good morning, Val.
Good morning.
We are here. What part of Jersey are we in?
Northern New Jersey.
Northern New Jersey. We're here in beautiful northern New Jersey, where there's plenty of construction, so don't even try to find Val's house because we had the address and couldn't do it. So we're here to talk about 2017 in review, highlights from a national perspective, from NHF's perspective, and from your personal perspective, as well as some look-aheads to 2018. So I have a bunch of specific questions for you, but before we dive into those, is there anything in particular that's top of mind as you, I'm sure like many of us at this time of the year, as I'm looking at the leaves outside changing color. It's a little colder. We're making Langston put on jackets. I'm sure you're starting to reflect on 2017 a little bit. What comes to mind for you when you think about this year in the community?
There were a couple of big things this year. One was our fight to protect healthcare. Biggest Washington Days we've ever held. 500 people coming. Lots of visits to members of Congress.
There's a second Washington Days too, right?
Exactly. As Congress began to deliberate and they tried to repeal Obamacare, we felt it was necessary to have a second wave. That was a targeted wave where we asked specific state representatives or people from our community to come in to talk to specific senators to get that vote turned our way.
Strategic targeting.
Sort of strategic targeting. We don't often do that, but we felt it was necessary. Clearly, that was a budgetary stretch for us to do. Washington Days is not something that we can support from our corporate donors. It's something that we have to do ourselves, and so it's always a big stretch of our unrestricted dollars to do that. But it was well worth it. We won the fight. At least initially. I would suspect that this administration will continue to try to pick away at healthcare reform. It is the only route to, in my mind, it's the only route to them having a successful tax reform thing. They need to find the money somewhere to offset what they're planning to do with tax cuts.
Which is also, so it's worth for community members too to mention that even in we're hearing now a lot about tax reform plans, even built into a headline of tax reform are some pretty significant healthcare threats. So even under a different umbrella, healthcare is still something that's in jeopardy. So we have to kind of be paying attention and fighting the fight on multiple fronts at the same time.
Exactly. I mean, that's the complexity of legislation, is that you can write a number of things into a bill that affect a broad variety of categories, and the devil is in the details.
Right.
So It's one of the first things I learned. It's not what's on the face of the bill, but you need to read every line and see how it impacts your agenda, your community members, their access to care. And that's what we're worried about all the time.
Is there anything in particular going into 2018 with regard to protecting healthcare that that NHF is thinking about or may do differently or may try in addition to existing efforts that you've learned from this year might be important in order to continue protecting the ACA?
I think we have to continue to just pay attention to the access issues, making sure that people have access to their products, making sure that pre-existing conditions don't become an issue, making sure that lifetime caps don't sneak their way back into the picture. If we can hold the line there, I think we'll be okay. Of course, we are worried, as any American is, about premiums, and premiums are dictated by how many people sign up for plans. My biggest concern is not premiums in the large states like California or Illinois or New York, but in smaller states like Alabama and some of the Midwestern states like Iowa, where the populations are smaller. The position of the state government has been against sort of ACA enrollment. So the enrollment is depressed, and therefore the premiums are much, much higher. There are solutions to that. If we could get Congress to work together, I think that there would be solutions to that. But right now we're in a very partisan time. So it's a very difficult conversation to have.
So we've kind of started to talk a little bit about premiums and insurance companies in particular, and I'm curious to know, can you give us a national overview of how our community has interacted with payers and insurance companies in 2017 that maybe has been a little bit different than in years past? And do you see in 2018 us operating even differently than we did this year in any particular way?
We've had a lot of good conversations with payers. What we did with the CCSC was we brought together national payers, Aetna, United Healthcare, and some other representatives of national and regional payer organizations, and we sat them down at a table with some of our leading HTC directors, those who had interest or had larger populations, or some of them have 340B programs, and started to talk about bleeding disorders and what we view as important, what our clinicians view as important, what the payer views as important. And what the first thing we found out was that they were speaking the same language but in different terms. So we speak of comprehensive care.
Right.
They speak of integrated care.
Right.
Essentially the same things, but when we say comprehensive care, they look at it through a lens of a cancer model that leads to higher cost for them. When you say integrated care, it's more specific to you're charging us for, or you're attempting to bill for, multiple services from a variety of caregivers who are supporting the patient, and they're okay with that.
And packaged within a system. Like I feel like in business, when we hear an integrated or a fully integrated model, the thought is that the cost savings because you're handling all services in house. So in a way, it's quite a shift from comprehensive equals expensive, integrated care equals efficient.
Exactly. I think what people misunderstand about payers is that they assume payers don't want to pay for the patient. And what the payers want is for the patient to receive the best possible service for what they're willing to pay.
Right.
Because unhealthy patients cost them more.
Right.
So one of the things that we learned about that, other than just sort of the language barrier that was happening, was that a lot of HTCs don't bill for all of their services. A lot of them don't, because they have over time believed that the payer doesn't want to pay for those services.
Interesting.
So, you'll get them billing for the doc services and the nurses services, but not so much for the social worker and the PT services. And when you think about the federal funding for the treatment center, it is for the nurse, social worker, and PT.
It's
side
pretty
of the
specific,
business.
right?
Pretty specific. But it doesn't mean that as a patient, when you go to a treatment center appointment, that you're spending all of your time with the doc and the nurse. As a matter of fact, most of the appointment is with the social worker and the PT, depending on what's going on with you at the time. Payers didn't realize how much of a role those other team members played in the patient's life. And they want to be billed for that. You know, I can't pay for it if you don't submit it. Was kind of their position.
I want to just call back one thing. We do have to move on to other topics, but you mentioned earlier specifically smaller states like Iowa and how they are the ones that you're more concerned about because they're smaller pools. So we heard news that there was a civil rights petition filed by NHF, HFA in conjunction, of course, with Hemophilia of Iowa against Wellmark in Iowa after they essentially ousted an Iowa teen with hemophilia as the reason for spiking premiums and ultimately pulling out of the market. I'm not sure what exactly you can say about this, but just in general, from a broad perspective, what does this mean for our community at large? Because we've never seen, NHF has never been involved in something like this before, right?
No, we've never filed a civil rights petition before. We felt very strongly that this patient's HIPAA rules were violated because it's a small state and they mention certain particulars, male patient, teenage, inhibitors. So there were triggers there that made the patient identifiable. The family felt a little exposed. The young man felt that he had jeopardized other people's insurance because he was targeted. And Wellmark used it as an excuse to pull out of the state pool, which I think they planned to do anyway, but they were kind of covering their tracks as they went. We did that because we felt the patient and the family had been violated. I think the larger picture of that is it sends a message that we will take that step to protect our community members anywhere that might occur. And I think that's a good reason. And I think the other great thing about that is we were able to do it in collaboration with HFA.
Right.
Which is something I focused on this year, was really trying to build that bridge.
And we'll maybe come back to that a little bit later when we talk about the memorial. But kind of staying along this track, we've also seen a proliferation in treatment options and in the pipeline of investigational therapies. We now have non-factor replacement therapies in the pipeline, such as emicizumab and fitusiran, and we may see emicizumab on the market in the U.S. here very soon. And for anyone who doesn't know, these are subcutaneous therapies that people with hemophilia could only have to take once every couple weeks or perhaps even more infrequently, and in my opinion, most importantly, hold tremendous promise for our inhibitor population in particular. But we've also seen some serious adverse events in the clinical trials for each of these therapies, including 2 patient deaths, 1 on each trial. So given all of that, what do you think is most important for a community to be thinking about when it comes to the rapidly expanding treatment landscape? Not necessarily, there's obviously an insurance and a cost consideration and a gray area that we don't really know too much about yet, but just from a broader perspective, as patients and families are hearing about these drugs in the pipeline, what should they be paying attention to? Because there's been a lot of news.
Well, I think, one, you got to be hopeful that a lot of these treatments are going to be available to patients. I think that's really the great thing about it. But I also think that from a organization and patient perspective, we've got to make sure that these products work best for us, meaning that as a community, we have to frame that picture. So as a person with severe factor IX deficiency, the standard of care for me when I was born was I clot at less than 1%. So getting me to 1% was sort of the standard of care.
Milestone,
okay,
yeah.
Right? You know, get me above 0. Okay, all right. Well, clearly, getting me above 0 to 1% really does nothing for me. I still have severe hemophilia.
Right.
Okay. Whereas a realistic treatment in terms of what people like to quote as cure, and I do put that in quotation
I can
marks.
verify that. He's doing it with his hands right now. There are,
Exactly.
there are quotes on display.
Would be somewhere in the 30 to 50% range. Okay. And when we're talking to corporations, you got to start that frame at the clinical trial level. If you're not shooting for 30% or 50%, then don't start that clinical trial.
Right.
Figure out the science and start it so it's going to be the most efficient product for us that you can design. And that's what I think patients should look for. They should look for the best of the best. I think it's a significant step that many of these products are going to be subcutaneous. I don't think people really grasp the value of that, not having to look for a vein ever again, or not having to have a port installed. Those kinds of things. That's a serious step in advancement for us as a patient, and will allow patients to be more compliant with their treatment plan if it's a subcutaneous stick. So those are great steps forward.
Absolutely.
But I think you also have to look at, as I tell all patients, clinical trials for people with bleeding disorder are small.
Right.
Okay. There's no indication what that's going to look like in the larger population.
Yeah, there's a reason we value real-world experience with rare disease populations, because there's just no way to get around the fact that the trials are always going to be relatively small. We're just a small population.
Exactly. And there's no value from a corporation side to have something go wrong in your trial.
Right. Yeah, they're not looking to throw that money away in those years of research.
Right. The penalties are too high.
Yeah.
To start over again, it's too expensive. So the patients that they're trying to recruit for those trials fit into a pretty specific categories. So it's a double-edged sword. You know, I wouldn't not participate in a trial. Lord knows we need people to participate in them so that
it's the only way we get any of these, right?
Right. But I would encourage patients to continue to be hopeful. Do your homework. Make sure you compare products that are in the pipeline. Try and find people who look at the products sort of objectively, and that'll be scientific groups like ISTH and ASH and others who will look at it from a scientific point of view rather than the company's sort of marketing point of view, and see what's going to work best for you. Ask lots of questions, but participate in the clinical trials where you can, and be hopeful for the future. I think our future is very bright in terms of treatment. My task as CEO of the National Hemophilia Foundation and many others in leadership roles is, how do we reimburse these projects that are going to cost lots and lots of money? And there is no precedence for a product that might be 6 figures per infusion.
And we're starting to see think pieces being written about, what will this all mean? And I guess we'll just have to find out when we get there.
There are a couple of alternatives that we can look at. European health organizations have found ways to pay for high-cost drugs. The question is that transferable? There's a big difference between a single-payer market and what we do here in the United States.
Right.
I think it's achievable. It's going to take a lot of conversation. It's going to take a lot of buy-in. But there's
bipartisan policy
exactly.
efforts.
But there's no reason why bleeding disorders can't be first, and that's what I like to think about. There are a lot of biologics in the pipeline for a lot of chronic illnesses that are going to be very expensive.
Yes.
But there's no reason why bleeding disorders can't be first to conquer that hill.
Well, I love the sound of that. Hey, sorry to interrupt the conversation with Val here, but just wanted to take a quick moment to once again recognize the exclusive sponsor of the BloodStream Podcast, Shire. We always say thank you to Shire on this. We try to do it in some ways that are kind of fun and stick out a little bit. But truthfully, we are extraordinarily thankful for their support of this new media effort to get you the latest information, the most interesting news, and quality interviews with people of interest to the bleeding disorders community. We appreciate all their support, and we look forward to going forward with them in 2018. So for everything they've done for the BloodStream podcast, we say thank you, Shire. So, all right, let's switch gears a little bit to speaking about the VWD population, but really the greater bleeding disorders community, because it is the National Hemophilia Foundation, but as the tagline states, it is for all bleeding disorders. So talking a little bit about VWD and then other bleeding disorders as well, NHF has made a concerted effort to increase support for people with VWD, rare factor deficiencies. There have been what I'll call more subtle shifts, such as the tagline being for all bleeding disorders, the rebranding of the walk to unite all for all bleeding disorders. And then there have been programmatic shifts, such as having factor 10 and factor 13 programming at annual meeting for the last couple of years, increased programming for people with VWD. So as we look ahead to 2018, how will NHF continue to amplify the support for the VWD community and the rare factor deficiencies and for all bleeding disorders?
I think where we have to go as an organization, and thanks for noticing that we've made a concerted effort to broaden the tent, as I like to say, is now we have to do it on the science side of it. The foundation's got to get behind research for VWD. We've got to get behind research and better products for the rarer disorders. There's certainly lucrative for factor 8 and factor 9 to some extent, and we see lots of products for those two particular bleeding disorders. So the goal is to try and recruit corporations to make products for those smaller populations.
Let me, if I could follow up with you on that in particular. I'd never quite thought about this until just now, but given that there is this proliferation of treatments for factor 8 and factor 9, and as you mentioned earlier, we have to decide what kind of therapies we'd like, and we know the importance of access and choice, but there is also a reasonable threshold at some point where we don't need 150 products for hemophilia A. So is there a strategic reasoning that a company may decide, you know what, this market is saturated? And we're talking about this from a corporate standpoint right now, but these are for-profit entities after all. Is there a strategic reason, or is there a way that maybe NHF and other organizations could kind of help a roadmap develop for these companies to be incentivized to create products for these rarer bleeding disorders?
Some of the companies, that's their focus. So if you look at some of the companies, they're more focused on the rarer disorders. They're not trying to compete in the larger markets of factor 8 and factor 9 because they know they can't. So it's kind of like how many people switch, okay, once you're on a product. Do you know what that number is?
I know it's low, right?
It's like 5%.
Yeah, it's really
Okay.
low.
So if you look at it that way, then from a corporate standpoint, what am I trying to do here?
Right.
Okay. Am I going to get 30% of the market? Probably
highly
not.
unlikely.
Okay. Can I make a living off of 1-2% of the market? Absolutely. So when you talk about those numbers, then it does become profitable to make a product for a smaller group of people. You're not necessarily going to see the large market sharers in this area try to do that, okay, because they already have the lion's share of the market.
Right.
But those who have, let's say, less than 10% of the market, they are going to be more interested in making a product for a fewer number of people because there's a niche to be made for rarer diseases, not just bleeding disorders. So having some success with bleeding disorders will lead you down the pipeline to other rare disorders.
Right, it's an entryway for them.
Exactly, and that's why you work with those companies and support them and making a drug for our smaller populations.
That makes
And
sense.
to do that, you have to bring visibility to those populations, which is why we've made a concerted effort to highlight them at the annual meeting, have workshops specifically for those smaller groups. Not only do we want the patients to attend, but we want manufacturers to attend.
Sure.
We want them to embrace those smaller communities.
And that last year, the official designation now of March not being Hemophilia Awareness Month in a kind of casually traditional way, because President Reagan once said that, but now it's actually in the books as Bleeding Disorders Awareness Month.
Exactly.
Another effort toward that, I'm sure.
You know, we, it's funny, I get this a lot, and it all goes back to my grassroots experience in bleeding disorders, which is my camp experience and having a variety of kids with a variety of bleeding disorders and all being identified as hemophilia. And really hearing from them how grateful they were to be at a place where they could share their bleeding disorder, but seeing that there was sort of a hierarchy in terms of severe, moderate, mild, VWD, Glanzmann's, you know, whatever was your platelet disorders, whatever it was.
Right.
And this identity crisis for them. And especially true for von Willebrand's disease females, which I made a concerted effort to bring them into camp, or carrier status, but even more so for boys with VWD.
Yeah.
Who really feel, you know,
I'm betwixt and between here.
Exactly.
Yeah.
You know, so broadening of the tent is deliberate on our part, certainly deliberate in terms of who we hope to bring to the table. I think that our community is pretty small, okay? So I think the more people at the table gives us a better pool of potential leaders, potential supporters.
Oh, absolutely.
So that's why I, in my early years, opened the camp to siblings and carriers and others, because I felt we needed to broaden the pool. Everybody needs to be in the pool together so that we all feel a certain community to what we're doing. So Bleeding Disorders Awareness Month is, you know, planned to do that, broaden the tent so everybody can join under that tent. I hope that somewhere down the line that will lead to a name change for the National Hemophilia Foundation.
Yeah.
You know?
Yeah, I want to actually follow up on that. And you mentioned women with bleeding disorders, and I want to get to that next. But before we started recording, you said something that I found really interesting about why the name change is maybe more significant than a first thought might indicate to someone who's just kind of observing from afar and wondering, well, I have von Willebrand disease. We're a larger population than hemophilia. How come it's not bleeding disorders? What are we waiting for? But you mentioned the importance of kind of institutional knowledge and the foundation that the name hemophilia has in the minds of policymakers. Can you speak a little bit to that? Because I think that's such an and sorry, there's the last point. It goes back to that comprehensive versus integrated conversation we were having earlier. The significance of specific words. It may seem like semantics, or it may seem like, why are we calling this a disorder instead of a condition? There's a significance to the way these words are perceived by people that we need to be our allies. And I think that what you're about to say speaks to that very well. So please.
You know, so I've heard that before. It's like, why aren't we just change the name? You know, from the perspective that I'm in now is, one, it's very expensive to change the name, just practically. You know, you got to rebrand everything.
Oh, sure, yeah.
Every
chapter, everything.
Every chapter's letterhead and their signs, and everybody's got to do that. And if we're going to change the name, then certainly we want to support our local affiliates in being able to do that.
Right.
But more importantly, we have built the name about these bleeding disorders around hemophilia. So at the federal level and the state level, the local level, we're known as hemophilia.
Right.
In this great time of political transition or limited political institutional memory, changing your name could cost you some ground. So I thought you were hemophilia. No, you're bleeding disorders. Is that a different organization? So it's not that easily done. You can't just like change the name overnight.
Right.
And even if we do change the name, for years we will be formerly known as
Right.
the National Hemophilia Foundation until we completely make that transition. But we're starting that transition by Bleeding Disorders Awareness Month. So I want people to know that's the direction we're going in, but we don't want to lose any ground with people who have supported hemophilia, bleeding disorders for years. And
what's great about
understand that.
Bleeding Disorders Awareness Month and the Red Tie Challenge being connected to that, and as we've seen from just the social media response to the Red Tie Challenge, how often people are with state officials, federal officials, with the Red Tie Challenge talking about Bleeding Disorders Awareness Month. So there's already some grassroots work being done to begin that transition, and it's connected to a tangible, specific campaign in a month that's designated as such. So there's a nice seeding that's being done, but I think it's very valuable to hear, and it was new to me, and I imagine it'd be an aha for people listening, that it's a very strategic, well thought out transition that's going to take place over time. It can't and shouldn't just take place like that. So let's now talk about women with bleeding disorders. But I know that this has a unique place for you, and you've done a decent amount of work to bring victory for women into existence. Better You Know, trying to help more women and men get diagnosed if they have symptoms for a bleeding disorder, giving them a place to go to investigate that potential. So broadly speaking, what have been some of the successes for women with bleeding disorders in 2017? And what do you see as the work still needed to get done in 2018?
Well, clearly we've expanded our education options for women with bleeding disorders. You see that at the workshops at the annual meetings. So you see that as Better You Know. You see that in terms of the things we're doing in terms of outreach to women with bleeding disorders that include von Willebrand's disease, that include carriers, recognition. You saw us do, not us, but the partnership around My Life, Our Future, focused that final group on carriers specifically so that we could find out more about what they bring to the table scientifically. So it's all been about broadening our interest. After all, hemophilia is carried on the X chromosome.
All right.
Hi,
Mom.
Often women have felt diminished, burdened by carrying that weight.
Yeah.
There's been a lot of blame associated to that.
Hear guilt come up a lot.
Guilt come up for that. I know in my own personal case, I never could get my mother to go get her levels tested, even though I knew as she got older, joint disease was setting in, and I knew that she was struggling.
Interesting.
But she wouldn't do it. She was, I put all my time and energy into my little boy being well, and, it's not important for me. It's more important that you survive.
That must have been kind of hard for you to reconcile, though, personally.
Well, life is sometimes about sacrifice, and that was her sacrifice.
Yeah.
She wasn't so debilitated by it that she couldn't live with it. It was, to her, just part of getting old.
Yeah.
Whereas I saw it differently because I knew so much more about bleeding disorders.
Yeah.
Mom, your life could be easier.
Right.
So some of it comes from that. Some of it comes, again, from my grassroots experience, really working hard to bring young women into my camp, really working hard to support them in terms of growing into strong leaders. I had an experience recently at the annual meeting where I invited a couple of young women who had worked with me at camp up to have breakfast with me. And they brought their kids. And there I am sitting with two children, a baby and a toddler, on my lap, talking to them while their mother, who was a teenager in my camp, was just sitting there, beaming over the fact that we still knew each other, we still had a relationship, how special that relationship was. That's the quality of this community. So I've always felt it's a privilege to try and build that tent wider, give them a place in our community, a place of, authority, a right to be. So it's a very important agenda to me.
One more specific population that I want to touch on is Spanish language speakers in the U.S. And obviously, in the U.S. we've got people, talk about a big tent. We've got people who are all kinds of native language speakers, but we have a particularly high concentration of people whose first language is Spanish, and there are studies to support the claim that Americans that have where Spanish is the primary language of the household. And I think that's an important distinction, because that means even if the child is completely fluent and you wouldn't know him from anybody else, if the primary language in the household is Spanish, that in general they have lower health outcomes than those for whom English is the primary language in the household. Can you give some insight into how NHF has been working to improve community engagement with the Spanish-speaking segment of our community, both nationally and locally?
So in 2016, I went to California and talk about planting seeds. I went to California and I brought the 4 chapters together. And at that time, Central had pulled out. So it was 3 chapters. Hemophilia Council was there around a table. And I said to them that I wanted them to come up with a vision for patients in California. What did they want it to look like in 10 years? We're still working on that vision question.
Okay.
But in order to achieve the vision, I said one of the things that you need to do is prove to me and others that you can work together. Okay. And the opportunity I felt for them to work together was the Hispanic population. Here you have a large population within your state that you all try to serve, but you have limited resources to do so. So it's difficult to run Spanish-speaking workshops simultaneously to running all the other workshops you do.
Right.
Translation is expensive. Finding speakers who are fluent in Spanish that can really engage those populations.
Who know our community well enough and are literate enough. That's a huge,
exactly,
we've come across that
thing. So what I suggested to them was, why don't you have a statewide Hispanic conference and that you all participate in it. Now, the underpinnings of that were, how do I get these 3 or 4 chapters to work together on a single event? How do I link their executive directors in a way that they become collaborative, that they become interdependent on each other? And I felt there was an opportunity here to introduce a new idea that might bring them together and have them work collaboratively, because we all know in bleeding disorders, every place is a little fiefdom. Right. So you gotta work with the personalities that are in control.
Right.
And, sometimes that's great and sometimes that's an obstacle. So here was an opportunity to bring those groups together, have them focus on a singular project. And I'm happy to say that there was a statewide Hispanic conference. It was wildly successful. Industry supported it. Patients supported. The speakers were international in many cases. We got people up from South America who came and spoke, and I was really impressed with the program and everything that they did. And hopefully it will translate to either other states or other areas. And specifically, I wanted to transfer, I hope that it will transfer to states where we have multiple organizations.
Well, one more question for you before we wrap up here. It was about this time last year that you and I and many others were in San Francisco for the National AIDS Memorial Groves World AIDS Day ceremonies, which included not only recognizing the hemophilia community with the Unsung Hero Award, but it was also the kickoff to the National Hemophilia Memorial that will live within the AIDS Grove in perpetuity. There's been talk of a memorial for our community, for those who we lost to the blood contamination crisis for quite some time. I'm a bit too young to kind of be a meaningful part of those, but I'm well aware that this has been going on for a while, and now finally a memorial is underway. You're obviously a leader in this community, in case you didn't know that, in case CEO of NHF didn't make that clear. That comes with certain responsibilities, of course, but as a community member living with HIV who has also lost loved ones to AIDS, was in the front lines of the Ricky Ray Act battle, what does this memorial mean to you personally, and can you tell us where we are at in the process?
It was one of the most significant things emotionally for me to participate in as an individual with the bleeding disorders. One of the things they did during the ceremony was all of the names that were dedicated to be etched in stone as part of the memorial. They had name cards for all of them laid out, and you could read anyone's name, just get in line and read the name. So I went up to get a few names of people that I knew. I ended up walking away with 26 names that I read over the speaker, and I can't tell you what a moment that was. I mean, 26 friends that either had passed away or were significant parts of the march toward this memorial. People who had worked hard on the Ricky Ray Hemophilia Relief Act, people who were friends, people who were leaders, people alive and who had passed away. So it was a significant step forward, something I will cherish forever in my life. I was also impressed with the size of the memorial. I don't think I ever envisioned it as big. It's not what we talked about. It's so much bigger and broader than I talk about. It is the largest memorial in the Grove at this point. I mean, the way it's situated in the Grove. They built a ramp up to it for wheelchairs, and it's like almost a half-story tall from the ground up. And
forgive me, I should probably know this. Is it complete at this point?
The names still need to be engraved.
Okay.
And that'll happen over the next few months. We wanted to have them engraved for that day, but the limestone hadn't dried significantly enough.
Uncooperative limestone.
Uncooperative limestone, but the pattern has been laid, and as soon as it's available, they will etch the names. That won't be the only group. There's actually room for probably 1,000 names.
Okay.
We have about 300 that are going to go in initially. So there's room. The bench itself, where people can sit, will be etched with affiliate organization names who wanted to make a donation and be represented as part of the memorial. So it really is a community collaborative thing. We were happy to do it with the support of HFA, another bridge builder between the organizations. I'll give you a moment. So two things that happened that were significant. The folks who managed the Grove and board of directors and all that, one of the things that they mentioned, because the day that we dedicated the memorial was the day that they do the work on the AIDS Grove in general. So it's a big day for them. They do new plantings, they weed, they clear paths, they do all of these sorts of things, and we were there for our celebration. So about 200 of us came, in addition to the people that they had there. And what they said to me, what was different about us being there, was the number of children who were playing on the grass. Because normally when they do it with the gay population, lots of males,
right,
not a lot
many
of children
involved. Oh, interesting.
And that's what they remarked to me. They said, "This is amazing. The life that you have brought to the Grove."
Oh, that gives me goosebumps. That's really cool.
So the other moment for me was, you may know, we gave the Loris Getkin Award to Kimberly Huckstead this year at the annual meeting. Loris was a friend of mine from the early 80s who participated in the Men's Advocacy Network of NHF, and he was a true leader. His family was from Iowa, and his mother lost all 7 of her sons, okay, to HIV. And so I met a Getkin. She brought her family to the Grove to read his name into the thing, and I'd never met anybody from his family, so it was really a moment for me to meet somebody. Loris was a good friend, certainly a leader in this community. So we're going to bring her to the annual meeting next year, and she's going to give away the Loris Getkin Award.
Very cool.
Yeah.
We're kind of out of time here. Is there anything that we haven't touched upon that going into 2018, anything else that you'd like to share with community listening?
You know, I think our one of our, not challenges, one of our hopeful moves forward will be My Life, Our Future is ending up December 31st of this year. We hope to introduce a My Life, Our Future 2 with a different scientific focus. We want to continue the program. There's lots of research to be done. We've set up a pretty elaborate institutional review board, or IRB, among 103 treatment centers. We'd like to keep that going. We'd like to come up with some new scientific questions that we want to be answered related to inhibitors, related to von Willebrand's disease, maybe related to some rare disorder questions that we want to answer. A terrific opportunity for us as a bleeding disorder to keep the science going. A terrific opportunity for us to continue to build our treatment center network into a clinical data capturing group that makes us stronger and more dependent. I always tell people that the future of our disorder is in our hands. From a perspective, from a federal perspective, from a state perspective, we've got to own the information related to bleeding disorders. We can't compete with each other for that information.
Right.
We've got to own it as a whole. NHF, Athens, treatment centers, we all got to own that information so that when somebody wants to know something about bleeding disorders, they want to know whether our products work, they want to know whether we're compliant patients, they want to know whether we're receiving the services that we need, they want to know that all of this effort, that there's a real impact on the quality of life of people with bleeding disorders. We can derive all of that information by keeping something like My Life, Our Future open.
Oh, that's exciting to hear. All right. Well, I'm sure there'll be more news about that in 2018. And I guess an early Happy New Year. And thank you for doing this, Val.
You're very welcome. Good to talk to you.
Hey, hope you enjoyed that interview with Val. And just one last time in 2017 here on the BloodStream Podcast, we want to thank the exclusive sponsor, Shire, for making this episode and all episodes of the BloodStream Podcast possible. Thank you, Shire. I want to thank Val for agreeing to do that interview and kind of give us a state of the union in the bleeding disorders community from this year and a look ahead to next year. Great to kind of get his take and chat with him in his home in New Jersey last month and to just review the year together. It's, 2017 has been quite a year in a lot of regards, and it has been quite a year for our community, independent of all the other shenanigans and mischief going on around the world. So it was neat to get to go through that with Val. And to look ahead at what is to come. So with that, we're just wrapping up here. But before we go, one parting shot from Natalie and I, a final thought, bleeding disorders related or otherwise. And we will start it off with Natalie. Natalie, what is your parting shot, your final parting shot for 2017?
I mean, I'm going to go with the otherwise.
Go with the otherwise.
After being in India last week, where the temperatures were in the 80s and it's December, I haven't felt moved by the holiday spirit, per se. And then yesterday a few days ago, I landed in Germany. And the Frankfurt airport was so Christmassy. And I was like, oh, yeah, it's almost Christmas. And it will be Christmas a week from today. And yeah, I guess my parting shot is just wishing our listeners a very, very happy holiday season, whatever you celebrate, but that it's a season to celebrate family and love and reflection, and it's at the end of the year. Just, I'm excited. And we landed in New York and there's snow and it's, so I'm like, actually like, I woke up today like jolly feeling and like it's Christmassy. It's Christmas time, or holiday time. Whatever your beliefs are, it's a festive time of the year, and it's not always an easy time for everyone either. It brings up a lot for a lot of people. So just to make sure you take care of yourself and take care of each other, and I'll see you in the new year.
Yeah. And, reminder, or it gives me an opportunity to plug that we do have a Stop the Bleeding holiday special. It's actually our Christmas episode, but it's our holiday special episode. We'll put a link in the program notes, but you can see me dance around in a big fat Santa outfit. You can see Ryan Gielen dressed as a Sasquatch. A lot of great things going on in our holiday episode of Stop the Bleeding. Every great show needs their holiday special.
Yeah.
And we now have ours at Stop the Bleeding, and it is the season, so we'll put a link in the program notes if you'd like.
What's your parting shot?
My parting shot is on December 13th. The DailyMail.com reports that the WHO declares after months of deliberation, medical marijuana has no public health risks and should not be withheld from patients. They have acknowledged that CBD, the property of cannabis that's used in medical marijuana, it should not be a scheduled drug. And they go on to get more specific about that. But I continue to be encouraged, and since we've addressed this a couple times in the podcast, figured it was worth bringing this up, that we are trending in the right direction when it comes to looking at CBD and cannabis for the use of medical purposes and pain relief, and for benefits and things like epilepsy and Parkinson's and Alzheimer's disease and cancer. And there's a lot of
everything.
Yeah. And, it's going to take a while for us to chip away at all the red tape that surrounds using this stuff and the stigma associated and the way that it's weaponized for other reasons and blah, blah, blah. But it's just good to see that places like the WHO are coming out and saying we should not be withholding this stuff. We need to better understand it because it has the potential to change lives. And that's encouraging. So I'm encouraged that medical marijuana continues to find support, even though it's going to be an uphill battle for a little while yet. That's it. That's it, Natalie. We did it. We got to the end of 2017. Huh? How about that? So with that, that is all for this episode. You can check out BloodStreamMedia.com and subscribe to the BloodStream Podcast, the Ask the Expert Podcast, the Powering Through Podcast, and the Bloodline Podcast to hear all of BloodStream Media's podcasts for the bleeding disorders community. You can email us at mailbag@BloodStreamMedia.com. You'll also find Bloodstream on Facebook.com/BloodStreamMedia and on Twitter @BloodStreamInfo. This episode of the BloodStream Podcast was written by Patrick James Lynch and Natalie Lynch, produced by Patrick James Lynch, Ryan Gielen, Rob Bradford, Andrew Gall, Josh Bragg, Alva Friedman, Heather Robin, Colby Crow, and the BloodStream Podcast is edited by Mr. Andrew Gall. Special thanks to everyone at Believe Limited, the National Hemophilia Foundation, Entertainment to Effect Change, the Hemophilia Alliance, and, of course, Shire. Thanks as well to our Share segment contributor, Angel Parrett, as well as to sit-down guest, Val Bias. Reminder to check out the program notes for this episode in your podcast player or on bloodstreampod.com for links and additional information about the various stories featured on this episode. My name is Patrick James Lynch.
And I'm Natalie Lynch.
And until next time and next year, take self-care of yourself. Bye, everybody. Happy holidays.